So, how do we modify running? One of the basic principles I like to use with my patients is any activity that's below about a 5 out of 10 pain wise is probably acceptable for Achilles tendinopathy. This is based on one study, which link in the show notes if you want to check it out, reference number 4, where they had runners with Achilles pain and put them into two groups. One group was not allowed to train through pain, run through pain at all. They were unloaded. Okay. They weren't allowed to run. The second group was allowed to continue running, but they weren't allowed to have more than a 5 out of 10 pain while running. So they had a 6-week period of unloading in the first group. The other group took 6 weeks of running with less than 5 out of 10 pain, and the long term outcomes were the same. Okay. So if you're okay running with a bit of pain, you're probably not going to delay your recovery or recover any less fast. Okay. If you run through a little bit of pain. So 5 out of 10 for me seems a little high. When I am running and my Achilles hurts that bad, it's a bit of a red flag, kind of pops up in my head. But this is what the literature shows. So I try to follow that guideline with my patients, and I definitely follow this guideline with her. Okay. Because at the end of the day, we don't want to stop running. There's a myriad of health benefits, and injury is a major threat to continuing exercise. That's the last thing we want to do. On top of that, we hit two birds with one stone because the patient actually wants to run. So if they come to you and say, I stopped running, I want to get back to running, and you say, no problem, let's start running again, they're going to be happy, especially if you can get them better at the same time. Pretty cool. Okay. What do we alter from a running technique perspective? Well, we changed cadence and we bumped it up to around 170, 175 because we know a faster cadence can reduce some of that Achilles tendon stress, right? Remember, she's a 4-foot striker. I didn't change that at all. I mean, if she was having long-term issues that weren't resolving whatsoever, no matter what we threw at her, then I would consider that. But that wasn't the first thing on my mind. I don't want to change too much, right? I don't want to throw a major wrench in her training that hurts something else. Okay. In terms of shoe wear, I actually recommended she try a cushioned shoe. And she had a few at home. She just hadn't worn them in a bit, and she gave it a shot. What was actually kind of nice is that at that point, with a faster cadence, right, slowing down the speeds a little bit, running was actually quite tolerable. So I didn't feel the need to change much more. But one of the pieces of advice I did give is that if you aren't able to run with all of this advice, right, you still have a ton of pain, let's potentially try a heel lift, right? So a soft kind of insert the back of the heel tends to be helpful in folks with Achilles tendinopathy. But at the end of the day, she never needed to. So we didn't have to change foot strike and we didn't have to add a heel lift. We were able to reduce pain just by changing programming and altering cadence, right? Which is great. So like I said, what we did do is change her running programming. And what that was adding a return to run program, which we'll talk about in a second. But the guideline was, hey, I don't want your pain to be above about a 5 out of 10 while you're training. And you should feel like the next day you're about back to baseline. Okay. And that's what we had used. Over the course of time, we slowly built up volume. I think a good rule of thumb is to ramp up your volume before ramping up intensity. Higher intensity, faster speed, simply put, puts more stress through the Achilles tendon. So I want to try to increase the volume before ramping up that intensity. Okay. The other thing that's important is that you might want to figure out what ends up hurting your patient. So some patients can actually run for long periods of time, high volumes without any pain. And as soon as they turn on the intensity, it starts to hurt. Now, you'll also have some patients where they tolerate intensity, but it's the volume that hurts. They won't start hurting until they get to minute 20 or 25 in some of their long runs. So you can also make the argument that you want to try to taper down or take back some of the stresses that are causing pain in the first place and not automatically assume it's an intensity problem over a volume issue. Okay. Over the course of time, we transitioned to an 80-20 program, otherwise known as polarized training. We had a very slow buildup of intensity after we ramped up the volume some. Okay. The next thing we altered some was running surfaces. Now, if you remember, she was hurting when she was doing her trail runs. Now, this certainly could be because it's a longer run, right? Could also be because there's hills. Maybe she runs a little bit faster. But the other piece is that it's a softer surface. We have a little bit of conflicting data that shows running on a softer surface can increase your risk of getting Achilles tendinopathy. So if you're running on a softer surface, it might be increasing some of the stress on the Achilles, and the Achilles doesn't like it. So initially, we started off her running on a harder surface, right? So road running. And then over the course of time, we progressed towards softer running, trail running. We also eliminated hills initially, right? And then over the course of time, we introduced that back slowly. So in terms of strength training, we want to load the area, especially the Achilles, but really entire chain. I wrote her entire lower body strength program. Oftentimes, I'll work with trainers, personal trainers, strength coaches, where we're talking to the strength coach and kind of telling them what to do, what not to do. This wasn't the case. She doesn't have a strength coach. She doesn't have a personal trainer. I wrote the entirety of her lower body program. Okay. So what did this program look like? Generally speaking, 2 times per week, we're doing compound movements. What does that mean? Split squats, single-legged squats, step-ups, single-legged deadlifts, heel taps. When we were able to, we emphasize running posture with our strength training exercises. So if I can strengthen the muscles I want, make those exercises specific to running, that's going to be 2 birds with 1 stone, right? We want to do that. Next, we do isolation work to the calf or the Achilles. We're doing this 3 times per week. So that was calf raises, that was heel float work, direct strengthening for the calf, as well as compound movements that put the calf in a position where it's the weakest link. So it has to work really hard. Okay. We also focused on the hip musculature. Remember, this patient had some FAI. We focused on clams, abduction, side planks, flexion, and adduction, right? So Copenhagen planks. And keep in mind, there was a lot of hip drop during exercise, which might have been aggravating the FAI symptoms. So we tried to clean those up. And over the course of time, the hip pain did go down some, right? Eventually, we did more plyometric activity. Think about running. It's a lot of low-level plyometrics over and over and over again. Incorporating plyos into your rehab program is a good idea because that's specific to what your athlete wants to get back to, okay? We're doing that 2 times per week. How do we progress things over the course of time? From a calf perspective, we started with double leg calf exercises, and we progressed to single leg calf exercise over the course of time. And then we added load. Okay. You can also go from high reps down to low reps because it's not so hard to use a light weight and do high reps for the Achilles. As soon as we add more load, it gets harder and you have to decrease the reps. All right. We also started on a flat surface, so doing calf raises on a flat surface, and we progressed our way off the edge of a step. Now, I would be more cautious with this if there was an insertional Achilles tendinopathy, but there wasn't. It was mid-portion, so we could go pretty quickly into calf raises off a step as long as it's well tolerated. In terms of strength training compound movements, I'm a big fan of heel float work, which is basically doing, let's say, a step up or lunge where half of your foot is off the box, right? Or the front of the foot is elevated slightly, and you're doing a lunge or a step up pretty much on the ball of your foot, which puts a little more stress on the calf and the Achilles, right? I'm also a big fan of sled work to get ready for eventual plyometrics. I feel like the position is very similar to acceleration and running, and we're getting some good stress through the calf, through the Achilles in a way that's pretty specific to running, right? Without having that same speed of impact that you'll see in a plyometric, right? And if you want to see my favorite physical therapy exercises, I'll put a link in the show note. I made a video about this. I'll also put it right up here if you want to check it out on YouTube. All righty. After we were tolerating the strength program really well, I start putting plyometrics into the program, right? So as soon as your athlete is able to tolerate plyometrics, I'd recommend introducing a little bit at a low level, right? We started introducing plyometrics maybe 2 to 4 weeks after starting the strength program. My general rule of thumb is that physical therapy is kind of like making soup. You add a little salt, you taste it. Does it need more? Okay, put a little more. Taste it again. Does it need a little more? You keep on adding. Big thing is that we don't want to put too much salt in the soup right away. So I generally start with some strengthening. How's the strengthening going? Going well. All right, let's try some plyometrics. How are the plyometrics going? Good. All right, let's make the plyometrics harder. So we slowly increase over the course of time. We start with double leg plyometrics. We progress to single legged plyometrics. Initially, the jumps are more based around building capacity or tolerance. So I'm not trying to jump super high initially. I'm just trying to get the tendon used to that loading. I'll increase the volume a little bit over the course of time. As we're tolerating that well, we'll make the jump intensity a little bit higher. We'll focus more on power in terms of intent as opposed to just getting through the repetitions. Okay. We progress from single plane jumping to multiple plane movement, which may not be as important for runners. But if you were trying to get back to, let's say, soccer or a field sport, I'd say that's incredibly important, right? And lastly, I think plyometrics are sometimes a good way to sink the ship. What do I mean by that? So some folks just don't tolerate plyometrics especially well. Keep in mind, if you have a runner and you're having them run, they are doing plyometrics. So if you have them on a run program, plus you're doing a lot of strengthening, and then you're doing plyometrics on top of that, that's a lot of stress, and you may not even need that. Okay. So keep that in mind. So for a lot of my athletes, I don't even use plyos. And in the rehab of my own Achilles, I found that anytime I put in too many plyos, it sets me back. All right. So you have to be really careful with this, and also keep in mind that you are getting some plyometrics if you have them on a run program already. So here's what I want you to do next, guys. If you enjoyed this video so far, I have an entire course. It's free. It's called the Fitness Pain Free Mini Course. And we go over 3 lessons going to help you take a lot of this information that we went over so far and put it into practice. The first lecture is called Why We Need a Better System. So first and foremost, the way we treat fitness individuals, all right, athletic people in the gym from a physical therapy perspective is pretty much broke, okay? So we need a better system to serve the folks that are in the gym that get hurt, they want to get back to training, all right? Lecture number 2 is called 7 Reasons Why People Get Hurt in the Gym. And essentially, we have to know the reasons why people get hurt in the gym so we can keep them safe in the future, right? And when they get hurt, we have to know why and how to get them back to training in the gym. Okay, so a thorough understanding of this is very, very important. I actually have a really cool infographic that goes along with this lecture that you get for free as well. And lastly, we go over a case study of how to get someone out of pain and back to training. So these principles are all phenomenal, but we don't actually put it together and you don't understand how to create a program to get people back in the gym and keep them safe for the long term, then we lose, right? So I'll put a link in the show notes for this. It's a fitness pain-free mini course. Definitely check this out.